She is an elderly lady with bilateral iris coloboma, bilateral retinocoloboma, and she also has this black cataract in one eye. Slit lamp examination shows mild phacodonosis, and in the inferior quadrant, we're not able to observe any zonules. So it looks like in this area, zonules are missing. And this is the maximum pupillary dilatation which we can attain with the drops. So this is quite a handful now. The plan is to do manual small incision cataract surgery, so I'm planning a superior incision in this eye. The main aim of the surgery is to be quick and easy extraction of the lens, and I'm just hoping that if I can preserve the bag, I can consider stabilize the bag with the rings and then maybe place the lens into the bag. But in the scenario where I may not be able to save the bag, which looks more likelihood, so I'm also ready with an iris claw lens. So let's see how things turn out. 1.5 ml of lignocaine is injected in the inferior middle quadrant, and a small amount of lignocaine is used to raise a bleb in the superior quadrant where the incision is being planned. A conjunctival flap is created and a scleral incision is being performed, which is 1.5 mm from the limbus. Using a crescent blade, a sclerocorneal tunnel is fashioned, which is approximately 6.5 to 7 mm in width. The tunnel extension into the cornea is about 1.5 mm. This ensures a good valvular action for the tunnel. So when you're dealing with these hard, bulky cataracts, we can always opt for a slightly lesser long tunnel. That is, the distance between the external and the internal corneal wound, we can try to have it slightly lesser so that the extraction of the nucleus becomes a little bit more easier. The two side ports are made. I'm wondering, should I stay in the capsule or not, because I'm concerned that the dye can go across this inferior area into the burger space, and which may lead to loss of the red reflex later on. But trying to save the bag was a primary goal for me. I thought that by staying in the capsule, I can visualize the capsule better and the chances of trying to save the bag would be better. So I decided to go in with the trypan blue. I'm using as little stain as possible, but still I can see that some of it has trickled down posteriorly. OVD is placed into the bag. The internal corneal entry is done and it's extended all the way laterally on either side. Now, before doing the rexus, I thought if I have better visualization, especially in the superior part, I have a better chance of getting a good rexus and a faint possibility of saving the bag as well. So I resorted to using iris hooks so that I can see well. I'm using the iris hooks through the main incision and also through the side port so that I get better visualization, especially in the superior aspect. Now, during the insertion of this third hook, as soon as the hook touches the lens, you can see that the lens is just too wobbly. So at this point, my hopes of saving the bag are dwindling. So time to perform the rexus. The moment I touched the capsule with the needle, well, I knew that this bag is not going to stay. It was very difficult for me to even puncture. The lens was just moving left and right. Eventually, I could just manage to puncture it. And with the rexus, I tried to create as big a rexus as possible, but the nucleus and the capsule were so adherent to each other, it's just not possible to separate them with either doing hydrodissection or not. And I could feel that the zonules which are left were very minuscule. So at this point, I decided that intercapsular extraction is the best way to go forward, and using the two Sinskey hooks, I am including the capsular bag when I'm trying to mobilize the nucleus out into the antechamber. With relative ease, the entire nucleus could be maneuvered into the antechamber. The two superior iris hooks which are introduced to the main wound were released. The cataract is sandwiched between the vectis and the dilator, and the lens is eventually extracted out. The two iris hooks are gently maneuvered out. At this point, I'm just trying to figure out that whether vitreous prolapse is there, and I'm just using diluted triamcinolone acetate, trying to irrigate it out. There doesn't seem to be any prolapse vitreous as far as now, but definitely some amount of lens matter has seeped into the Burgess space, and so anyway, I had to remove it, so I thought I'll better do a vitrectomy. Mind you, there is no glow at this point because it's the dye has entered into the vitreous cavity. So I'm using a irrigation in my left hand and the cutter in the right to the two side ports, and I begin performing the limited anti-vitrectomy. The lens particles which were there is cut and aspirated along with the OVD and probably some amount of antivitreous as well. So once the visual axis is clear, now is the time to place the lens. So I'm using a cohesive OVD to maintain the chamber here. The planned iris claw lens is gently negotiated into the antechamber, placed over the surface. Then it is rotated to ensure that both the haptics are in the horizontal meridian. And then using the Clayman forceps, one haptic is gently maneuvered under the iris, and through the side port, a 26G cannula which I use for hydrodissection is used to gently push the iris down, and the appearance of a knuckle or a pucker in the iris is a sign that the enclavation has been successful. I come out, the hands are switched, and the similar enclavation is being done on the other side. Now since the pupil is slightly bigger than what I would have liked, I believe the enclavation is not gone into the most peripheral part as I would have preferred. Nevertheless, the lens seems to be reasonably centered and very well enclaved. The OVD both in front and behind the lens is removed by using the cutter. Mind you that going behind the lens through the main incision itself. So in a vitrectomized eye, if you go through a closed chamber, sometimes there could be sudden deepening of the chamber. So to minimize that, one trick is to always go through the bigger incision and then go underneath the iris claw lens and remove all the OVD which is behind, and also some of the OVD and muck which is sticking onto the posterior surface of the lens. So once the antechamber is also clear of all the OVD, time to close. I'm just using a single radial stitch in the superior quadrant to counter against the astigmatism which would have been introduced because of this large incision. Absence of vitreous is confirmed by using diluted triamcinolone acetate. The conjunctival flap is closed. That's it, the case is done. Now these are the first day post-op pictures. The patient has contact fingers 3-meter vision, and she's quite happy with this visual outcome. So that was it. Thank you for watching and hope you found this helpful.